Regional Distance Learning Seminar Series conducted by Pediatric Center of Excellence pCoE JNIMS. Today we have First Line ART Initiation in Infants and Children, and the speaker will be Professor N. Kameshore Singh. Professor N. Kameshore Singh, MD, PGI, MER, Chandigarh, CCT, TMH, Mumbai, DM Fellowship, Clinical Hematology, AIMS, is currently working as Professor and HOD of Pediatrics, JNIMS, Imphal, and Program Director, pCoE JNIMS. He has been in the State Health Service as pediatrician for more than 20 years. He is also recipient of Pioneer Award of East Zone Academy of Pediatrics in 2005. He has attended many NACO, WHO, and UNICEF trainings related to HIV/AIDS and working in this field for the last many years. He served as the Honorary State Secretary, Indian Academy of Pediatrics, Manipur State, and Joint Secretary, East Zone Academy of Pediatrics 2015. He has published many papers in both national and international journals. He has also presented papers in state, journal, national, international conference. Now I hand over to Sir.
For the introduction. Good afternoon, ladies and gentlemen. The presentation of today's RDLS is ART initiation in infants and children. After the guideline of test and treat all, timely initiation of ART is very important in the management of children living with HIV/AIDS. So, in this session, we'll discuss about this initiation, and at the end of the session, the participants should understand national guidelines on ART initiation in HIV-infected children. That is to know when, how, and what ART to initiate in children. And in case of HIV/TB co-infected children also, we should know ART initiation, when to start, how to start, and what is to be started. And for this, appropriate prescriptions, including ART formulations and the doses as per age group and the weight band of the infant and the children is very much required. So, the goals of ART in children are combination ARV therapy in ART-naive children living with HIV, and we should start with at least 3 ARV drugs, which may contain 2 NRTIs, that is nucleoside reverse transcriptase inhibitors, and 1 NNRTI, non-nucleoside reverse transcriptase inhibitors. Or we can start with 2 NRTI and 1 boosted protease inhibitors, thus producing slowing down of the HIV disease progression, sustaining virologic response better, and delays the development of resistance with these 3 drugs, and at the same time normalizes immune function and improves survival and quality of life of the children. So, before starting ART, baseline clinical assessment is very important. We should include growth and nutritional assessments like weight, height, head circumference, and the left mid upper arm circumference. We should do developmental assessment, clinical staging of the HIV disease, at the same time identification of the active opportunity infections including tuberculosis, concomitant medical conditions, pregnancy in adolescent girls to be identified, details of concomitant medications including cotrimazole and traditional and herbal therapies are also required, and we should have a detailed immunization history. And in case of the adolescents, tenor staging of sexual maturity is to be done. Let us see what are the considerations to be done before initiating ART. And in the following few slides, we will discuss this. All people with confirmed HIV infections should be referred to ART center for registration in HIV care. So the first thing is registration. Then second, baseline status assessment of clinical and laboratory evaluations. Then thirdly, treatment of pre-existing opportunistic infections. Fourth, treatment preparedness counseling and timely starting of ART initiation. So while doing this, the following principles are to be kept in mind, and treatment should be started based on the parents or guardians' informed decision, which is very important, and a preparedness to initiate ART with an understanding of the benefits of the treatment, requirement for lifelong medications, and at the same time issues related to adherence and positive preventions to be addressed properly. Informed consents to be taken from the parents or legal guardians of children or adolescents if they are less than 18 years. And this informed consent form we will show in the next slide. When it is decided to start ART, one should also consider the child's social environment and the identification of clearly defined caregivers who understands the prognosis of HIV. Requirement of ART is also very important. A caregiver should be identified for each children to provide adequate support, and caregivers must be counseled properly, trained to support treatment adherence, and they should ensure about the requirement of follow-up visits and sharing of decision-making processes. Co-trimestral preventive therapy CPT should be started in children as per the guidelines given by the NACO. This is the that consent form which is to be signed by guardians or patient caregivers if the child is or adolescent is less than 18 years. Next. So continuing this consideration before the initiation of ART, all patients should be screened for TB, which I have already mentioned, any presence of active opportunity infections. For tuberculosis in children, we can use 4 symptom tools, that is current cough, fever, poor weight gain, and the history of contact with tuberculosis. And if those children who do not have tuberculosis, we may start IPT, that is isoniazid preventive therapy, in addition to ART. And ART should be started in the presence, should not be started in the presence of active OI, as I have mentioned already. In general, the principle is opportunistic infections should be treated or stabilized before the commencement of ART. In case of the Mycobacterium avium complex and the progressive multifocal leukoencephalopathy, the commencement of ART itself may be preferred treatment, as this will decrease the infections, and also especially when the specific MAC therapy is not available. So let us see how these clinical conditions are addressed before starting ART. For example, any undiagnosed active infection with fever, we should try our best to diagnose and treat first, and start ART when the condition is stabilized. In case of the tuberculosis, we start treatment of tuberculosis by ATT and start ART as soon as possible after 2 weeks and before 2 months of the starting of the anti-tubercular drugs. But for those with CD4 less than 50 cells, 50 cubic millimeter, then we can start ART within 2 weeks of the starting of the ATT. But caution is needed for people living with HIV, TB, meningitis, since immediate starting of ART is associated with more severe adverse events. Then we may start ART 2 months after the start of ATT treatment of tuberculosis. In case of the PCP, then we have to treat the PCP first with cotrimazole or other available drugs. Start ART when PCP treatment is completed. Regarding the invasive fungal diseases, including esophageal candidiasis and penicillosis and histoplasmosis, we start treatment for opportunity infections of esophageal candidiasis first, then start ART as soon as the patient can swallow comfortably. We should treat penicillosis and histoplasmosis first before starting ART, and after the patient is stabilized or opportunistic infection treatment is completed, we can comfortably start ART. In case of the bacterial pneumonia, we treat the pneumonia first and start ART when treatment of pneumonia is completed. Likewise, in malaria, treatment of malaria is done first and start ART when treatment of malaria is completed. In conditions of acute diarrhea, which may reduce absorption of ART, we can diagnose the cause of diarrhea and treat it appropriately and start ART when the diarrhea is stabilized or controlled. In case of the non-severe anemia, for example, hemoglobin less than 9 gram deciliter, we can start ART if no other cause of anemia are found, because it is known that HIV infection itself may be the cause of anemia. Skill conditions such as PPE and seborrheic dermatitis, psoriasis, HIV-related exfoliative dermatitis, we may straight away start ART, because many of these conditions, they may resolve when after starting ART. However, in drug reactions, we do not start ART during acute drug reactions. If we suspect Mycobacterium avium complex, MAC, cryptosporidiosis and microsporidiosis, we start ART, because many a times ART may resolve these problems. However, in case of the cytomegalovirus retinitis, start treatment of CMV urgently and start ART after 2 weeks of CMV treatment. Toxoplasmosis, also we start treatment of toxoplasmosis first and start ART after 6 weeks of treatment and when the patient is stabilized. In case of the severe acute malnutrition, that is SAM, ART should be started as soon as possible after stabilization of metabolic complications of SAM and sepsis. That usually happens after 7 days and after establishment of F100 diet. Let us see what baseline laboratory investigations are to be done before initiating ART. The CD4 count or CD4 percentage is to be assessed. CBC, that is including hemoglobin, to be done. Urine sugar and albumin is tested. Fasting blood sugar, serum creatinine and ALT is measured. Blood VDRL test, X-ray test, pregnancy test in case of the sexually active adolescent girls, and other investigations according to the signs and the symptoms of the suspected or any identified opportunity infection should also be done. Additional tests which may be required are directed according to the symptoms and the signs. For example, in case of the suspected tuberculosis, we can do CVNet and of sputum and the body fluids. We can do sputum for smear microscopy and AFV staining, ultrasound abdomen, CSF analysis, and other investigations depending on clinical presentation, symptoms and the signs, and the suspicion of any infections. Hepatitis B surface antigen, anti-hepatitis C antibodies tests should be done in children living with HIV if there is history of intravenous drug user, multiple blood and blood products transfusions, and strong clinical suspicions when ALT is more than 2 to 3 times of the upper limit of normal. For patients to be initiated on protease inhibitor based regimen, baseline blood sugar, liver function tests, and lipid profiles are to be performed. But we should remember at the same time that ART initiations shall not be delayed for performing these special tests. And let us see how this CD4 measurements is useful in the context of treat all. Baseline CD4 is important to monitor treatment response, identify complications like iris, anticipate OI infections related to the level of CD4 count, identify the need for OI prophylaxis, for example, CPT, and other immunization advice. CD4 level is also considerably higher than in adults. However, this CD4 level slowly declines to adult levels by the age of 5 years. Therefore, the immunologic criteria in HIV-infected children up to the age of 5 years, they are different from those HIV-infected adults. Compared to absolute CD4 count, the CD4 percentage in young children varies less within the age groups. Therefore, in children less than 5 years of age, CD4 percentage is considered a more reliable marker of immunodeficiency. Therefore, general guidelines are we should assess the family's psychosocial readiness for starting ART, and all the baseline assessments, investigations, and counseling to be done, and the initiation of ART to be done as it is not an emergency before doing all these things. When deciding to start ART, one should also consider the child's social environment, which I have already mentioned, including identifying a clearly defined caregiver who understands the prognosis of HIV and the implications of identifying a second caregiver which is used as a backup caregiver. Disclosure of HIV status to older children is important, and their family members improves adherence and should be encouraged with support from trusted health professionals. A family's success to adequate nutrition and support is equally important during ART therapy. So, next very important aspect is preparedness counseling. Treatment preparedness counseling for the children and the caregivers in the following aspects are to be done, like accepting the HIV result and a diagnosis, management of opportunity infections, and they should accept that ART is a lifelong treatment under National ART program. Readiness for treatment adherence to be assessed, and 100% adherence is to be achieved. accepting the positive prevention methods, particularly in adolescents. And the nutrition counseling is very, very important because nutrition is important during ART therapy, and there increased requirement of nutrient requirement. Health and hygiene care of children to prevent opportunity infection is also to be addressed. First line ART initiation for treatment of HIV infected infants and children. The first thing to be done is confirmation of the infection by virological test if it is less than 18 months of age, and by serological test if it is 18 months old or more than 18 months. And we should do baseline assessment clinically and at the investigations and the CD4 counts, treatment and stabilization of the acute opportunity infections and other acute infections, and start appropriate first line ART now, regardless of age groups, WHO clinical staging, and the immune status, irrespective of the CD4 counts. Let us see pediatric ART regimens. The choice of drugs depends upon the child's age, weight, and the presence or absence of anemia. We used to take 9 gram deciliter as a cutoff. In case of the microcytic hypochromic anemia, which is very common in children, particularly between 6 months to 36 months, iron supplementation may be necessary. In children with HIV infection, zidovudine is the preferred NRTI for initiation at present, but in case of the anemic children, hemoglobin less than 9 gram deciliter, abacavir is to be considered as drug of choice for initiation of first line. For all children age above 10 years and body weight above 30 kg, tenofovir is preferred drug for initiation of ART. Stavudine is phased out at present, but it may be considered in special situations. In case of the dual toxicity for both zidovudine and abacavir, use of stavudine may be considered as an alternative in children less than 10 years and a body weight less than 30 kg, where tenofovir cannot be used. Lopinavir ritonavir is recommended as a preferred drug, third drug in all children less than 3 years of age. For children older than 3 years and more than 10 kg, efavirenz is recommended as a preferred third drug during ART. Rationale of using lopinavir-based regimens in children less than 3 years, and this is a need for a potent first-line regimen in young children in context of high viral load and rapid disease progression, and hence this recommendation is based on the evidence of superiority of lopinavir-ritonavir-based regimen for young children. Now, evidence is suggestive of the superiority of lopinavir-ritonavir regimens for children less than 3 years, is regardless of the PMTCT exposure and given high prevalence of NNRTI resistance. Lopinavir-ritonavir was demonstrated to be superior to nevirapine. This also regardless of the NNRTI exposure during PMTCT regimen. And a systemic review of 2 randomized trials also have shown that children younger than 36 months have a reduced risk of discontinuing treatment and biological failure or death at 24 weeks if we use lopinavir-ritonavir. Lopinavir-ritonavir has a low failure rate and a better resistance profile that protects against the selection of NRTI resistance without compromising the use of other protease inhibitors in second-line regimens. Another reason is the desirability to have one preferred regimen for younger children less than 3 years while providing alternative strategies that remain less costly, preserving second line options. So let us see first line ART regimens in infants and children less than 3 years. If the hemoglobin is equal to or greater than 9 gram deciliter and not on concomitant rifampicin containing ATT, then the recommended regimen is zidovudine, lamivudine, lopinavir, ritonavir. If the hemoglobin is less than let us see with the pointer. If the hemoglobin is less than 9 gram deciliter and not on concomitant rifampicin containing ATT, then we select abacavir instead of zidovudine, as hemoglobin is less than 9 gram deciliter. Remaining lamivudine and lopinavir, ritonavir is the same. If the hemoglobin is more than equal to 9 gram deciliter and the concomitant use of rifampicin, then we use zidovudine, lamivudine, lopinavir, ritonavir as per weight, but super boosting with ritonavir. And if super boosting is not possible, we may use nevirapine as per body surface area. When hemoglobin is less than 9 gram deciliter and a concomitant use of rifampicin containing ATT, then as hemoglobin is less than 9 gram, we select abacavir. The remaining are the same, that is lamivudine, lopinavir, ritonavir with super boosting with ritonavir. And if super boosting is not available or not possible, then nevirapine can be used as per body surface area. Those with intolerance or contraindication to both zidovudine and abacavir, as I have already mentioned previously, in such special situations, stavudine-based regimens can be used as alternative, but after approval from pCoE, CoE, and SACEF. So we have to keep in mind that any regimen initiated for infants and the child must be based on body weight. Every visit, body weight check is being done for children and infants before writing the prescription, because as per body weight we may need to change the regimen in the subsequent follow-ups. First line ART for children aged 3 to 10 years. So if the hemoglobin is more than 9 gram deciliter or equal to 9 gram deciliter, regardless of concomitant rifampicin containing ATT or not, we can use efavirenz containing ART, that is zidovudine, lamivudine, and efavirenz. If hemoglobin is less than 9 gram deciliter, regardless of the concomitant rifampicin containing ATT or not, we can use abacavir, lamivudine, and efavirenz. For children with intolerance or contraindication to both zidovudine and abacavir, as mentioned already, stavudine can be stavudine-based regimens can be used, but after approval of the CoE, pCoE, or ART plus or SACEF. And the other remaining advice are same, because at every visit we have to check the body weight of the infant and the child before writing the prescriptions, and we have to adjust according to the body weight. Regarding the first line ART regimen for children more than 10 years of age and body weight more than 30 kg, we can use tenofovir, lamivudine, and efavirenz. And first line ART regimen for all new children age above 10 and weight greater than 30 kg, except those with non-renal disease or those with confirmed HIV-2 or HIV-1 and 2 infections, we can use this TLE, tenofovir lamivudine and efavirenz. And zidovudine, lamivudine and efavirenz can be used as a first-line ART regimen for all children aged above 10 years and weight more than 10 kg if hemoglobin is more than 9 gram deciliter with non-renal disease. Because with renal disease we don't use tenofovir. And first-line ART regimen for all children aged above 10 years and weight less than 30 kg or equal to 30 kg with hemoglobin more than 9 gram deciliter also we can use zidovudine, lamivudine and efavirenz. However, we have to choose abacavir, lamivudine and efavirenz as first-line ART for all children aged above 10 years and weight more than 30 kg with hemoglobin less than 9 deciliter with non-renal disease. That means with non-renal disease we avoid tenofovir, and according to the hemoglobin level we select either zidovudine or abacavir. Tenofovir, lamivudine along with lopinavir, ritonavir can be used in all children above 10 years and weight more than 10 kg, which is the criteria for using tenofovir, and with confirmed HIV-2 and HIV-1-2 infections, except those with renal disease. We can use tenofovir, lamivudine and lopinavir, ritonavir. So let us summarize ART initiation in children. The first thing is confirmation of the HIV infection, virological and serological testing according to the age. Then we treat and stabilize acute conditions, acute infections and opportunistic infections. Baseline CD4 testing is to be done and other lab investigations required as mentioned already. Then we see the age of the children. If the child is less than 3 years, then we see the hemoglobin. If the hemoglobin is more than or equal to 9 gram deciliter, zidovudine base along with lamivudine and lopinavir, ritonavir can be used. If the hemoglobin is less than 9 gram deciliter, instead of zidovudine we select abacavir and along with lamivudine, lopinavir, ritonavir. But however, if the age between 3 years and 10 years, we see the hemoglobin first. If the hemoglobin is more than 9 gram deciliter or equal to 9 gram deciliter, we use zidovudine, lamivudine and efavirenz, because efavirenz can be used in this age group. If the hemoglobin is less than 9 gram, instead of zidovudine, we select abacavir and the rest of the two, that is lamivudine and efavirenz. In case of the age more than 10 years, body weight is to be seen. If body weight is less than 30 kg, we use the previous two regimens, and if the body weight is more than 30 kg without any known kidney disease, we choose tenofovir, lamivudine and efavirenz. If it is kidney disease is there, we select the previous regimen as in between 3 to 10 years. So let us see, for drug prescriptions, we have to refer to the Annexure 2 of NACO Training Technical Guidelines, which is published in updated in October 2018 with drug dosage charts. And at the same time, please note that any infant and a child initiated on any regimen must be continued on the same drug regimens regardless of change in body weight or increase in age. In subsequent visits, we have to check body weight of the infant or child before writing the prescriptions, because we have to prescribe according to the weight band. Even though the drug regimen remains the same, drug dosage has to be modified according to the change in the body weight of the child. Always refer to dosage chart before writing the prescriptions. ART in children living with HIV having tuberculosis co-infection, as it is important and common. HIV-infected infants and children and adolescents, if it is co-infected with tuberculosis, we have to start ART regardless of the CD4 count. This is the general advice, but we have to start anti-tubercular drug first and initiate ART after treatment of tuberculosis is tolerated and between 2 weeks to 2 months. However, if the co-infected patient with CD4 count less than 10 cells per cubic millimeter in children above 5 years of age, we need to start ART earlier, say within 2 weeks, with strict clinical monitoring. And in this case, efavirenz is the preferred drug whenever the child is being treated with rifampicin containing drugs. However, in children less than 3 years or body weight less than 10 kg, where we cannot use efavirenz, superboosted lopinavir ritonavir is to be used. And if the age is less than 3 years and the body weight is less than 10 kg, then zidovudine, lamivudine, superboosted lopinavir ritonavir is to be used. Of course, the hemoglobin should be more than equal to 9 gram deciliter for use of the zidovudine. If it is less than 9 gram per deciliter, avacavir to replace the zidovudine along with lamivudine and superboosted lopinavir ritonavir. If the age is between 3 years and less than 10 years, and the body weight is more than 10 kg and less than 30 kg, then if the hemoglobin is more than 9 gram and the body weight greater than 10 kg, we can use zidovudine, lamivudine and efavirenz. And if the hemoglobin is less than 9 gram deciliter, instead of zidovudine, we have to use avacavir, lamivudine and efavirenz. However, if the weight is age is more than 10 years and the body weight more than equal to 10 kg, then TLE may be used. Regarding the co-trimosazole prophylaxis, all HIV exposed infants and children, they should start co-trimosazole prophylaxis from 6 weeks of age. That is, at a first or at any first encounter, and it is very reasonable, it is very convenient to call them at 6 weeks for starting co-trimosazole, for starting the 6 weeks immunization, and for taking other prophylactic drugs. All HIV infected infants and children up to 5 years of age, we do CD4 count in the percentage, and we start co-trimosazole prophylaxis regardless of the WHO stage and the CD4 counts. All HIV infected children, if it is more than 5 years of age, we give co-trimosazole prophylaxis if WHO clinical staging is 3 and 4, regardless of CD4 count, or if the CD4 count is less than 350 cells per cubic millimeter, regardless of the WHO staging. And the secondary prophylaxis after the treatment of PCP. And this is regarding co-trimosazole prophylaxis in children living with HIV during treatment with ART. Next. So let us see some case scenarios as time is available. So let us see the case 1. Baby, an HIV positive child aged 2 years and 3 months, that is less than 3 years, also have persistent oral thrush. She has achieved normal developmental milestones but has failed to gain weight, height as expected. The weight is 8 kg, height is 75 centimeters. CD4 count is 18%, that is 500 per cubic millimeter. Hemoglobin is 7 gram deciliter. Let us see what ART should be prescribed to this baby. We have to see the hemoglobin, we have to see the weight, age and the weight. So, the first choice of NRTI in children who are anemic, that is less than 9 gram deciliter, as in this case is abacavir. Therefore, this baby whose hemoglobin is 7 gram deciliter less than 9 gram has to be started on abacavir, lamivudine, lopinavir, ritonavir, because we cannot give efavirenz as it is less than 3 years and should be prescribed as per weight band. So for this ART initiation, we have to identify the caregiver, we have to do counseling of the caregiver, and regarding preparedness treatment, nutrition counseling, requirement for follow-up visits, and at the same time, initiation of the cotrimazole should not be forgotten if not initiated already. Let us see the case 2. Master S, HIV positive boy, 6 years, that is between 3 years and 10 years. Asymptomatic, weight is 18 kg, which is appropriate for the age. On clinical examination, general physical examination is normal, no abnormality detected. CD4 count is 386 cells per cubic millimeter. Hemoglobin is 12.6 gram deciliter. Other investigations are within normal limits. So what should be the ART prescribed for this 6 years old boy? Let us see. This boy 6 years, body weight 18, hemoglobin 12.6 gram deciliter. As hemoglobin is more than equal to 9 kg, we can use zidovudine. And the child's age is more than 3 years and the weight more than 10 kg, we can use efavirenz. So this child 6 years, 18 kg, hemoglobin 12.6, zidovudine, lamivudine and efavirenz is to be prescribed as per weight band. But we should not forget identification of the caregiver, and the second backup caregiver is to be selected if possible, and better also. At the same time, the caregiver should do proper counseling of the preparedness of treatment, requirement for lifelong treatment, nutrition and counseling, follow-up requirement for good adherence, preferably 100% adherence. And as the child is more than 5 years, CD4 count is more than 350, and asymptomatic cotrimazole prophylaxis is not indicated. Let us see the case scenario 3. 13 years boy, that means age more than 10 years, and children living with HIV, ART knife, asymptomatic, weight is 38 kg, which is appropriate for the age, hemoglobin 10 gram deciliter, more than 9, CD4 count is 458 cells per cubic millimeter, renal function test is within normal limits. So, and other investigations are also within normal limits. So, in this 13 years old boy, what ART can be prescribed? Let us see. So, we can use tenofovir, age more than 10 years, weight more than 30 kg, lamivudine, and efavirenz. As tenofovir can be used in children above 10 years, body weight greater than 30 kg, and no renal function abnormalities. Next. Case scenario 4. Arun is a 2 years 9 months old HIV infected boy who presented with the symptoms of cough, low grade fever for last 1 month. His father was recently detected to have pulmonary tuberculosis. So there is cough, fever, and the history of contact with tuberculosis. So after thorough clinical examination and investigation, Arun was diagnosed to be suffering from pulmonary tuberculosis. So, and put on anti-TB treatment, category 1 anti-TB treatment, and his weight was 9 kg, age less than 3 years, CD4 count is 14%, and hemoglobin 9.8. Then let us see when to start ART. No doubt, anti-tubercular treatment to be started first. And let us see what ART regimen is to be given. So, does Arun need to be started with ART immediately? No, because he is having tuberculosis and he has to continue ATT for at least 2 weeks, and we can start well between 2 weeks and 2 months before initiating ART. But remember, co-trimethoprim prophylaxis to be continued and or to be initiated if not started before. If and when ART is to be started and what drug regimen is to be used. Efavirenz cannot be given in children less than 3 years. And however, the Arun is not anemic as hemoglobin is 9.9 gram deciliter. So this Arun, 2 years and 9 months old, has to be given on zidovudine because hemoglobin is more than 9, lamivudine, and superbostate lopinavir ritonavir as the child is less than 3 years and on tuberculosis therapy. So, but as the child is on tuberculosis therapy, ATT, superbostate ritonavir, lopinavir should not be forgotten. The key points are all the HIV infected infants and children have to be initiated on ART regardless of the clinical staging and the CD4 count. And before initiation, all the required baseline assessment, counseling, investigations to be done, and 3 drugs based first line ART should be selected, which is either zidovudine or abacavir according to the hemoglobin, plus lamivudine and lopinavir ritonavir or efavirenz according to the age, that is 3 years, below lopinavir ritonavir, above efavirenz, depending on the age and hemoglobin as I have already mentioned. Both the child and the caregivers should be counseled, which is very important regarding the preparedness of treatment, requirement for lifelong medication, and requirement for follow-up visits and nutrition. Next. Thank you. Thank you so much for the patient hearing, and I hand over the mic to
Thank you, sir. If there is any queries, anyone can ask since we have few more times. Okay, so there is no more questions for sir. Okay then. Thank you, Professor and Kameshore Singh, for today's session. So you have clearly explained when which regime to be started for infant and children living with HIV, with or without TB co-infection. How early infant initiation of ART benefits children living with HIV, and all those uh, how it helps in stabilizing, and how to stabilize OI if there is any present before initiation of ART are all explained, and to monitor children body weight before prescribing ART, as children ART regime are on the weight base. So with this we come to an end of today's session. Thank you everyone for joining here, and hope to see you all again in the next session. Thank you.